to get the formal talk started. Thank you for joining us on this wet and rainy late afternoon towards the end of the semester. We have a really interesting speaker today, Professor Gabriela Marcu, who it comes from Drexel University, where she just started as an assistant professor in the information school there. And she graduated with her PhD very recently, snatched right up by Drexel from Carnegie Mellon in the HCI Institute, the Human Computer Interaction Institute. And HCI is her specialization, her area. We have lots of people here who are interested in that. So I'll turn it over to you. We have the room for an hour, so
Okay.
But obviously it's great to take some time so we can ask questions.
Yeah.
So it sounds like you're already getting questions.
Yeah.
Great, thanks.
Okay, thanks. You just did this, but the only thing I'll add is that I am from California. I grew up in the Bay Area and went to UC Irvine, so I always feel at home here. And just defended my dissertation in June and moved to Drexel at the iSchool, which is now known as the College of Computing and Informatics. So just a year ago, the iSchool came together with the computer science department and formed this new college. So it's very exciting. We're growing. We're hiring a ton. Lots of exciting stuff happening there. So that's my plug for Drexel. So what I'll be talking about today is my dissertation, the work that I did at Carnegie Mellon. And that was on coordination in health services. So this is sort of the problem that I study. This picture was drawn by a mother of a child with special needs who has to juggle a ton of providers and services and agencies, and it's such a headache. She sat down one day and actually drew it all. And for all the kinds of specialists, from neurologists to dentists to special education programs, transportation to school, advocacy and support, legal and financial, lots and lots and lots of stuff. And this kind of diagram I see a lot and I think represents really well this problem of how many different services people often have to juggle, and that they're all siloed and they're not sharing information with one another, and how challenging that is. So in the literature, this problem is known as continuity of care, and lots of people have been writing about this, the fact that we really, really need to provide patients with a sense that services are actually connected over time and place. And this is especially important because we've seen an increase in chronic conditions, which is anything that lasts over 3 months. And when I say chronic conditions, I mean both physical health and mental health. And what this means is we need to look at long-term care, collaboration among providers and agencies. There's a higher involvement of patients and caregivers. And there's this movement toward team-based care or shared care, are the terms that I hear a lot. And team-based medicine is something that David Lawrence talks a lot about and wrote a book about. He's from Kaiser Permanente. And this book is really great and talks about how big of a problem coordination is, and how much we need to move more and more towards team-based medicine. And he talked about a personal example when his father's health was ailing. And he said, in those last weeks before his death, I was unprepared for how hard it was to get the information I needed to help him make decisions about his treatment and care arrangements. Being a local medical school graduate and an executive in a large medical organization didn't help. I was just a son, joining my brother and sister and father's wife to help our father navigate a medical care system ill-suited to deliver what he required. And I think it's really telling that somebody in his position, with his knowledge and expertise even, has a hard time navigating our system. So how do we provide the sense that services are connected over time and place? Well, better information exchange and communication among different stakeholders, right? And one of the ways that we're doing this is we're going paperless. Doctors' offices, healthcare providers no longer look like this. We have these really beautifully designed electronic health records. And the goal of them really, of these health records and other health information technology, has been to reduce human errors and costs and increase coordination and best practice. But this promise has not been realized. There's an increasing amount of literature that shows the problem with them, and that we really have not reached the potential and the promise that we wanted to with health information technology. So here's one example of the many documented unintended consequences of health IT. That introducing an electronic health record actually decreased the amount of collaboration that was happening because the doctors are at their terminals. And so we see this siloing effect and lots of other unintended consequences. And so what's happening is we're losing these social aspects of coordination. And the way that electronic health records are being built and designed are deleting the social and ignoring the social aspects of what's going on. And we don't have an understanding of how providers realistically share information with one another. Yes?
In that cartoon, one of the doctors is looking at somebody else's x-ray. That's a violation of HIPAA, right?
No, I'm not sure. I think what this is trying to get across is that when they were not on computers on terminals, the two doctors were looking at it together. And then now when they're electronically...
Oh, those aren't two separate cases? I thought they were two separate cases.
No, they're just, the idea is just to show that they're now looking at a terminal on their own instead of looking at something together, collaboratively. Yeah.
This was like the x-rays before they had electronic.
Exactly. Yeah. And the way I always think of it is now how I go into any doctor's office, and the way that the conversation happens is really like this. And they're typing and they're asking me questions and not even looking at me. So you're losing that human touch, you're losing the coordination across the providers. So just one example of the unintended consequences. So what I contribute to this literature with my dissertation was looking at coordination and temporality and splitting up what it means to coordinate in a time-critical setting with acute care, and when something is long-term with chronic care. So there's a lot of literature in this area. A lot of the health informatics stuff looks at hospitals, emergency rooms, trauma teams. So there's a lot of really great literature here. And this is an oversimplification to make a point, but a lot of the literature tends more toward structured, sequential, predictable care. So when there's a protocol in place that needs to be followed, and we pretty much, it's more linear, and it's something that can be standardized. And what I studied was with chronic care, with long-term care, it's more unstructured, iterative, unpredictable, and it has to be very adaptive and individualized for the needs of each person. So we know a lot less about this side of things. And so that's what I studied, and I came up with this concept of collaborative reflection to explain what coordination looks like and how to help us understand how to design for these types of situations better. So this problem that I'm looking at is what's known to designers as a wicked problem. My goal here was not to fix it, but to understand it better, and through a design process to mitigate the negative consequences that I saw in the literature, and to improve the trajectory of the way that we design these systems. And so in doing that, these were my research questions. I wanted to understand the role of data in coordination, how it's used, what is needed for coordination to truly be data-driven, for data to actually be used in coordination, and how we can design information systems to support that process. I used anthropology-inspired methods. So a lot of basically what that means is fieldwork throughout the process, including naturalistic observation, contextual inquiry, and interviewing. So in HTI, sometimes fieldwork is not this lengthy. So in sort of HCI terms, as an HCI researcher, initially I took an action research approach to understand the problem and define the problem with the people I was studying, and did contextual inquiry in the actual context. So not in the lab. And then started designing something to address the problem that I saw using participatory design involving the end users in defining the problem as well as the appropriate solution. And then going through agile development. And then finally, once I had a system developed, I deployed it back in the field and did what in HCI is known as an in-the-wild study. So again, not in the lab. So, so this fieldwork throughout, the term that I like best for this approach is design anthropology, immersion in the user culture, and then co-creating meaning with the people I was studying and not just being the researcher that gets to define the problem and solve it. So that's how I looked at these research questions. Together with the people I was studying, we figured out what the role of data is and how to support this data-driven coordination process. Yes?
Okay, so can I ask a question?
Yeah, please.
I mean, you basically do ethnography, right? But is it more?
Yes, but ethnography that leads to design. So pure ethnography is, I think to true ethnographers, as an HCI researcher, I didn't publish a book at the end of it, and the goal of it wasn't the knowledge itself, to understand the culture really well, but to use that knowledge to design something and develop something.
How's that practice? How's it different than, say, taking field notes and doing different?
I did not do it to the extent that a true ethnographer would. I only spent months, not years. And went, I think, in practical terms, and took less notes and spent less hours than a true ethnographer might.
So I
Please, yes.
I wrote a book, and I spent about 10 years working on environment. Not a full 10 years in the field, but a year to start with, and then periodically for 6 years. And I didn't design it.
Thank you for the question, though. Good question. An immersive and iterative process. At the top, these are pictures from the field. At the bottom, those are pictures back in the lab where we did affinity diagramming and mock-upping and iterating through the design of a system. And then going back into the field and coming back into the lab and iterating on the design some more. Now, for the context that I did this work in was behavioral and mental health services for children. So as I said, I wanted to look at long-term, unstructured, iterative, unpredictable. So the sort of the opposite of the hospital setting with protocols that are followed. Behavioral mental health services were a great example of this. So what do I mean by behavioral mental health services? So let me give you some examples of behaviors, and I'm mostly focused on 2nd to 6th graders. So Ernie, and these, I can't show you their real pictures or tell you their real names, but these are real examples of real kids that I studied. So Ernie backtalks to a staff member and tells her to shut up. Zoe gets frustrated with her work and rips it up. Abby has been caught by her mother taking things home from school like a Sharpie or a ball, so she's stealing. And Bert throws a desk across the room and bites a staff member on the arm. So these are behaviors. And if I want to take a look at what mental model we should look, what model we should look at these behaviors with. So typically, we have 2 different ways of labeling these types of behaviors. The individual is either sick or they're bad, and they end up in the mental health system or the criminal justice system. So the services that I focused are based on a 3rd model, which considers an individual injured. And this is really cool stuff by Sandy Bloom, basically trauma-informed care and a school-based care that's known as the sanctuary model. So I'm saying this up front because I want to address the stigma associated with kids having these behaviors. So in realistic terms, these behaviors are not appropriate in a typical classroom setting, and so these kids get kicked out of school and end up in a different if they're lucky, end up in this type of school that has this model and provides the right services. So that as they grow up, some of them might always need these services, some of them might not. But then as they grow up, they might not end up in the mental health system or criminal justice system. So this requires a lot of coordination across agencies. As I said, these kids, they might have diagnoses of ADHD, autism spectrum disorders, trauma, oppositional defiant disorder, whatever the diagnosis really is, the services focus on the behaviors. So they'll probably get kicked out of public school, and what I focused on is known as a partial hospitalization program, sort of a step above special education, and it's not focused on the academics, it's focused on the behavioral, emotional, and social needs of the child, which need to be addressed before you can get to the academics. So that means trauma-informed care and cognitive behavioral therapy and behavioral reinforcement, so the type of services you might find in a psychiatric hospital, but it's partial hospitalization because they go to school, they get these services within a school setting, and then they go home at the end of the day. So the kids ended up at this school, and during the course of my field work, some of these kids moved. One went back to public school, one had to be hospitalized for a couple weeks and then came back. So they don't sort of move back and forth based on how they're doing, what their needs are. So my approach to looking at healthcare holistically and understanding the ecosystem and how coordination happens across the ecosystem started with doing fieldwork at the organizational level in order to then understand how they manage data within the organization, and then how that then does or does not get shared with parents, with other agencies, with the state, with whoever else needs to know what's going on with this child. So that's my timeline, again, just a mere month spent in the field. So my formative fieldwork was the 71 hours across 7 different organizations that were partial hospitalization or special education type of organizations. And that's where I got a sense of what this type of coordination looks like. So it's very adaptive and individualized by nature to serve these kids. They collect behavioral data, which basically means their social interactions, their ability to manage their emotions. And they look at frequency and duration of behavior so that over time they can see that the good behaviors have increased, the problem behaviors have decreased. And these are basically the 4 categories under which those behaviors go. So the kids should be safe, use kind words, follow directions, and complete their work. And that data is obviously going to be really individual and subjective, and so it needs to be interpreted and manually recorded by trained behavioral specialists. And I say this as because I have a background in computer science, so there's a lot of great people in computer science who are looking at automated ways of sensing this kind of data using computer vision. So I complement that kind of work by looking at technologies that can help people manually record this kind of data in situations where you need the trained human to interpret what's going on. So the trained humans that I'm going to focus on are, here again, some pseudonyms. I named them Jonah, Olivia, and Claire. These are the 3 people I spent most of my time with. They are the data wranglers and the student wranglers. They sort of did a lot of the legwork. So Jonah is sarcastic but overachieving. I have some great sarcastic quotes from him, but he was really, really meticulous with data, which is part of why they wanted me to study him and work with him. Olivia is easygoing and adaptive. She was just really gung-ho for trying something new. And Claire is often frazzled, and she's my skeptic. So she was my goal. If by the end of the study I could get her buy-in, then I knew I'd done something right. So this environment is really unstructured. Here's Jonah's classroom. He's the guy at the front of the room. And in the yellow are 2 staff members, and the bluish green are 4 kids. Total in this classroom are 4 staff and 7 children, just to give you an idea of the ratio. And this picture, I captured them actually all sitting at their desks and looking at the front of the room, but that's somewhat deceptive because actually here's my diagrams of each of the classrooms. They actually spent time at these stations and rotated in small groups in stations. So, they sort of have a schedule, but it's really a lot of unstructured work. And very unpredictable, because again, this is the kind of stuff you'll see on the walls, and this is what a lot of the conversation between staff and the students is about, is emotion management, social skills, addressing these behavioral and emotional issues. The iterative aspect is the way that they collect this data on paper and look at it over time and adjust interventions over time to make sure a child is doing better. Everything is done on paper. They're creating these graphs by hand on paper. And it gets sorted in binders. And here come my sarcastic quotes from Jonah, where I started realizing how much of a problem this is and how much tension this is. He describes it as they're turning this into an office job inside a petting zoo, outlining the fact that he's the one having to provide the interventions and supervise the kids and also manage data, which is totally unrealistic. And when Jonah would sort of try to say to his supervisor that this was really unrealistic and they needed more support, those conversations wouldn't go so well. He asked them to, maybe we should do some time studies, maybe you should figure out how much time this is really taking us to manage all this data. And his supervisor tried to say, why should we do that? This isn't a factory. But to them, that's what it felt like. So I was really fascinated by this idea that they're having to collect all this data, they're having to use paper, and they haven't found a better way to do it. And the more I spent time around, the more I realized that they had tried. They kept saying to me, like, there's got to be an app for that. And even Excel, they sometimes used, they sometimes didn't. But it became clear to me that there's just nothing out there that quite meets their needs. And so it became a design challenge for me, and this is why it became my dissertation topic, to see if I could design something that did meet their needs and that would fit within this unstructured, unpredictable environment, which is part of why they kept going back to paper. So the individuals involved in coordination, the three I've been focusing on are the behavioral specialists who, as I said, provide the intervention and prompting while also being the record keepers. And they're near the bottom of this diagram because they spend day in, day out with the students. They know them really well. And the higher we go up, the more the therapist provides cognitive behavioral therapy, will come into the classroom and do some social skills coaching. So they might see a student maybe once a week, twice a week. For example, one of the types of knowledge that a therapist might provide to this entire team that coordinates care for one child. Grover talked about during his cognitive behavioral therapy the fact that he hears gunshots when he's at home. All 5 kids are sleeping in mom's bed. The mom has a lot of anxiety. So there's clearly a lot of things going on at home. And so she shared this with the rest of the team. The psychiatrist then recommended medication to help with his anxiety when it became clear how much was going on at home. And the behavioral specialists who were working with him in the classroom sort of know what might be causing these behaviors. And then the clinical supervisor was the one that was saying how much data needed to be recorded and making those demands of the people down below, and supervised services. And then the parent, the communication between home and school was really, really bad. So that's a whole nother dissertation, a whole nother topic that I may eventually get to. But obviously they also have the most experience with the individual. So the lower we go, the better those people know the individual, the higher we go, the more expertise that person has. And the point really is that together they have this collective knowledge. Each person in this team provides a unique type of knowledge that's important, and so they're reciprocally interdependent. And the way that they work together is recording data, reflecting on the data, and then corroborating their interpretations of the data. And this is, I'm going to start skipping some stuff because I'm running out of time. And that feeds this long-term process of determining an appropriate intervention, applying the intervention consistently, evaluating whether the intervention's working, and disseminating information on progress. So that's the process that I call collaborative reflection. And we see that sort of coming out in their data sheets that they're using. There we see sort of the objectives, the goals that they're working towards, the intervention that was applied, and then how much improvement they saw. But you can tell it's a really simplistic way of presenting the data. So we're starting to see the problem that I really saw was that there's this disconnect between the data that they're collecting and the decisions that they're making. And in this long-term process, they're actually not coming back to the data. And that's what I looked more into. So some of it becomes clear when you look at their data. And this is each column is a different type of data they're recording. And each row is 2 or 3 weeks of data. And when they're getting together to look at the child's data, this is basically all they're seeing. And when they set goals to work towards, it looks like that. The goal is 84% of these points. Did that student meet that goal or not? So what I found was that data, realistically long-term, does not drive coordination because it's not representative, informative, or accessible. So here are some examples. Claire and her team were talking about this student, and the psychiatrist sort of tried to summarize. Again, the psychiatrist is at the top, and they're not seeing the student on a daily basis. And the psychiatrist said, he seems to be doing better based on the data that I'm seeing, and the brief moments that I've seen him in the classroom and hallway, he seems less irritable. And Claire immediately pitches in and says, see, this is that the data really is not representative of how this student is actually doing. The data should be telling us when he's supposed to be on task, is he? But it's actually showing something else. The therapist then suggests, since the data is apparently accurate, but it's not reflecting how he's really doing, what if we separate a behavior out and record that separately? Basically, why don't we collect more data? And the therapist suggests that because she's not the one collecting the data. Claire is. And Claire, being the frazzled one, sort of laughs nervously and says, that would be really hard. You're asking me to collect even more data? But it was really interesting where this conversation went about it's how non-representative this data is. And if somebody externally from the organization, like an auditor, were to come in and look at just the numbers, it would not be reflected that this student is really where he is. How can we better reflect that he still needs to be in this program? Otherwise, somebody from the outside may think, oh, he's doing great. Why is he still here? Why is he in this program when he could be in a typical school? So very not representative data. And that showed how difficult it was. Despite all the data they're trying to capture and how much work it is for people like Claire, it's not easy to make them representative. They're also not very informative. They would look at, again, these sort of tables of numbers, and it turned out that there would not be enough details in there, so Claire would add something off the top of her head, like, well, I would say maybe 5% of those points happened when he was out of the room. The property destruction data that we're looking at was mostly when he was outside, he was destroying plants and things like that. Jonah did a similar thing. They were talking about Murray and how he doesn't understand appropriate space. So when Murray's talking to somebody, he tends to touch them and be really, come up really close and touch them. And so Jonah was explaining that I have to prompt him a lot. I say, how long is your arm? That's how far you should be when you're talking to somebody. And the therapist responded, well, we don't have any data on how much we prompt him for that. But anecdotally, how much would you say that you do it? So it's interesting that they don't, even with all the data they're collecting, it's not detailed or informative enough, and so they're still relying on anecdotal evidence. And so these decision makers, like the therapists and psychiatrists, as you go up top and they don't, you go up that pyramid diagram, they don't have access to records that are informative enough so that they can understand the students as well as somebody like Jonah might. And finally, the data is really not accessible. It's not presented to them in a way that's very useful. The therapist asked Jonah how many timeouts Murray has had recently. And Jonah looked at a data sheet just like that one that we see at the top, he flipped through his binder and he looked at that blue ink. And he did a little ink test. And he said, well, ink-wise, it looks pretty clean. He just scanned the page. And so they concluded that that data looks better than it did 5 months ago because there's less blue ink on the page. So that's sort of the extent of the data analysis that they're doing. And it's because they don't have accessible data or a way to look at trends over time. So these three became the main barriers that I saw to truly data-driven coordination and why there's this disconnect here. And when I went back to the data, the literature about unintended consequences, it started to make a little bit more sense why this is happening. The literature describes the problems with these technologies as overemphasizing structure. They misrepresent communication as information transfer. They misrepresent coordination as linear, predictable workflow. And they overlook the less formal aspects of coordination. They're also very important. So if we design towards the long-term, unpredictable, informal type of coordination, we can address those barriers. So then I looked at a little bit of organizational literature to understand some of the organizational features of how organizations work when they're providing long-term care. And those are loosely coupled. They have loosely defined roles because they have to be so adaptive. Their services are customized and malleable over time, and their problems are not well defined. And so the tightly coupled type of organizations are much easier to design for, and I think oftentimes electronic health records and other types of health IT tend more towards that direction because it's so much easier when things are well defined. And those tend to be mechanistic systems. So what I'm arguing for is more organic types of systems that support diffuse and malleable roles, flexible plans and changing goals, authority based on knowledge instead of position, and multi-directional communication. So this is, the organic type of system is what I focused on then during my design process. And sort of my thesis statement was, if we designing HIT as organic systems will promote that process of collaborative reflection and improve coordination. And that's what led me to the design of the Lilypad system. And that was focusing more on two organizations and the way that their coordination processes worked. And it was around addressing these three barriers. So providing support for those who are capturing records because it's so hard to capture accurate and representative records. Remember that data sheet that they did it was basically a clipboard that they had in the classroom. What I did was replace that with a iPad. For a while, they actually recorded data side by side to compare and to transition over. But the idea was that it was available to them in the moment as much as possible for the ad hoc type of work that they do and for capturing the data in the moment as much as possible. And then really simpler things from a technical perspective that made a huge difference for them. So oftentimes they'd have to add up tallies and add up points throughout the day, and just doing that for them automatically and showing them a running tally of how each student is doing was like huge to them. I still remember the day that we rolled out that feature. So we started with basic features and then would added features based on what their needs were and how things were going. And the day that I walked in and that feature had been rolled out, Jonah was like, oh my God, he was so excited. And it was huge just to have this little tally that updated automatically. We made graphs automatically as well, and that gave better access to informative records for the decision makers, the people who aren't in the classroom on a daily basis. They can go in and check the graphs at any time. They don't have to walk over to somebody else's office and ask for the binder, ask for the data. And it was just a much easier to interpret and analyze format that was that up top was a really interesting thing I saw during a meeting where they folded over the data sheet because it wasn't all in one place. So it was never really very easy to review. And that was something we tried to address. And then to make it more accessible, on the left there was how much detail Jonah was putting in for himself. In addition to the boxes that he was filling out with timeouts, all those little scribbles are additional details that he was putting in because he was so meticulous with data, which is great, but nobody else reviewing that can really understand his scribbles. So when he's transitioned to this, the Lilypad allowed him flexibility to put in the comments that he wanted, and they were much easier for other people to review, to access immediately, etc. So just aggregating all of the data instantly was huge, so that they wouldn't have to go through binders or wait for somebody else to graph the data for them. All right, I'm going to get to the deployment and validation of the design, which I did within one organization over 5 months. And what I wanted to see was, does the design as an organic system improve coordination in that context? So I, for 5 months, immersed myself in the organization, averaging 4.5 hours per week. Those green squares are the days that I was in. Total of 81 hours, and I also sat in on the team meetings to observe the conversations and see how those changed over time. Let me, there we go. So to validate Lilypad as an organic system, I looked at these 4 characteristics from the literature of an organic system. So how did Lilypad support diffuse and malleable roles across the staff members? One of the reasons they had kept using paper and even writing on their hands was because in such an unpredictable setting, the picture on the bottom was one staff member's desk in the classroom. And sometimes they sit at that desk and have the computer and the mouse and the clipboard. But if a student runs out in the hallway and they have to follow that student, they're then out in the hallway and they may not have grabbed the clipboard, and that's when they start writing on their hand. So you can see the little sort of post-it note that they would use too, even though the clipboard was right there. So that sort of flexibility and staff members having to jump in for one another was part of the reason that paper was easier for them and worked better for that. So it was very cool when by the second week, Olivia said to me that our system was becoming a part of her day, and it was actually integrating into the stuff that she was doing. And unlike other stuff they had tried, they were able to adopt it and adapt it to their practices. One of the reasons that I named her Olivia was because she was pregnant at the same time as Olivia Wilde. So Olivia was one of 4 women to leave or return from maternity leave during a 5-month period with 24 participants. And what was cool about this was that her replacement, who was being trained in data collection and the stuff that she was doing in the classroom, to replace her during her maternity leave, was able to pick up Lilypad without any additional training from me. So once she knew her role and how data was collected within that organization, Lilypad became just another way of doing that. So I saw her just sort of picking it up and starting to use it, and she didn't really need anything from me. So that told me that it was very intuitive and easy to learn. And by week 6, the non-record keeping staff were also getting enticed and interested in Lilypad, partially novelty effect, but the fact that they wanted to start using it to collect data was pretty huge because nobody really wants to collect data. Nobody wants that burden. Everybody's got enough stuff to do. So it's pretty cool that they actually wanted to help out with that and get involved. So I'd heard a lot of complaints about the different systems they had tried because they were not flexible enough for the kind of services that they provide. And Olivia here was talking to me about one system that I had, in fact, heard a lot about. And she sort of summed it up as it was not user-friendly, and that's why they had to go back to paper. And that was certainly part of it. But I could just tell it also was not designed for the way that they work and to fit into their workflow. Whereas Lilypad had worked for them, and it was it gave them the ability to record frequency and duration of behaviors, and it also didn't, by providing that the column on the right there is just free-form comments for them to type in whatever they want. And I wanted to leave that in so that it sort of, we didn't lose their ability to just jot down some notes about what had happened. And that was part of why it worked for them and it fit into their workflow. Week 4, I asked them how the transition to the iPad was going, and they were using the paper and the iPad at the same time. But Jonah and Olivia both said that they could easily switch to the iPad full time. And the main question that I asked really is there any data that you're not capturing? So A, is it easy enough to use, and is it, can you adapt it to your practices? And B, are we losing out on any data with this interface? And so that was a great point of validation. And we had iterated on the design by then and improved it until the only feedback we were getting from the users was, oh, can it also do this? Can it also do that? So adding functionality, which is really, really great that they see the potential of it and they want to add things. But there was nothing that didn't work about it. We had tweaked it enough. And the study lasted for 5 months until the end of the school year, but they wanted to keep using it. So the example for authority based on knowledge, this is a really democratic environment where everyone's reciprocally interdependent on each other for their knowledge. With all I had seen a lot of tensions between the record keepers and their supervisors that wasn't really helping with encouraging that kind of democratic environment. So, Olivia loved Lilypad, and she said, this is exactly what I've been asking for, and they wouldn't even let me use Excel. I'm not sure exactly who they is or why they wouldn't let her use Excel, but that sort of told me something about the tensions. And a lot of my design process was being the mediator between these people and all the different stakeholders and trying to make this something that brought them together and ease those tensions. And Claire, who's my skeptic, was skeptical and doubtful from the beginning, but it was cool when she really started understanding the point of Lilypad and where we were going with this. And she said, she sort of, I remember like the moment that her face sort of brightened up and she sort of got it. And I told her that my goal was to get them to transition completely away from paper, and that if the administrators would let me do that, that's where this was going. And being the skeptic, she said, well, I doubt they would let you do that. But that would be nice. And she sort of brightened up and she understood, and she said, oh yeah, that would save us a lot of time and help us understand the data better. And just getting Claire to say, that would be nice was a huge win. And another example of authority based on knowledge was in a meeting that I was observing where they were looking at the students' data, and one of the therapists in the room was not a therapist who was working with this child. She was sitting in on the meeting, and she piped up and she noticed that every time this student had a timeout, they had an issue with follow directions. That's what FD is. So that student hadn't been following directions. And she pointed out that, according to this, it looks like every time there's an issue with following directions, that leads to a timeout, which is an escalation. And so she suggested, is there something we can do at the point where that child is not following directions to intervene so that it doesn't lead to a timeout, so that the behavior doesn't continue to worsen. And she pointed that out, and she said, is this in fact the trend? Am I correct about that, and what can we do about it? And it was really interesting to see, because she didn't really have any authority in this. She didn't know the child. She had to ask, is that, does that seem correct to you, the people that know the child better? So that was a great example. And finally, the data representations that we gave them, from being able to scan these types of comments to getting percentages and graphs, were really easy for everyone to understand. And everybody also pointed out that these would be way more understandable for the parents than the way that their data is currently printed out in reports, or whatever they're sharing with the parents is not that useful. And so this is another future direction. And that was very cool that they were pointing that out. Yes, go ahead.
Did you, sorry. Yeah. Okay. Did you think about, or are you thinking about doing analyses within the application? So in that previous example, for example, you could maybe alert instead of having the human eye have to.
Yeah, automated alerts is another thing that just got scoped out of my dissertation work. So this design is for the iPad, for sort of the in-context, everyday, to sort of check in with the data, and notifications are definitely part of that, to let them know, like, oh, there's been a dip in the data, or the data's gotten better. And then the other thing I want to do is a web interface, so that when they have time to sit down and look at the data long term, especially the administrators who might want to compare classrooms, things like that, getting them off the iPad and getting them a more sophisticated interface to do more analysis, definitely. Let me wrap up. Nope, that's not what I wanted. Okay, so I'm continuing now that I'm in Philadelphia. I am in the process of nailing down a couple more schools to continue doing long-term deployments, continue adding features to Lilypad. There's a lot of excitement. It's a really challenging problem, because in special education, behavioral mental health services, you can't really standardize. So it's sort of this juggling adaptability and customization with a little bit of standardization. So it's something I'm continuing. And I'm also branching out to understand a little bit more broadly what data-driven coordination means. And my goal is to bridge this gap between a lot of great work that's being done in data science and analytics and the stuff that I study, which is the social and humanizing process of coordination. So how do we bridge that gap, and what's in the middle? And there's this really great quote from actually a blog for executives about how important data science is and how great data science is going to be for business. But machines do analytics, humans do analysis. So as a human-computer interaction researcher, what is the interaction there, and how do we support that? And in addition to behavioral mental health services, I'm looking at this also with Title IX coordination at universities when they get complaints about sexual assault, and how they handle those. Legal teams, student services, law enforcement all have to coordinate at the same time around the data. And also a community health center in Philadelphia I'm starting to work with that provides holistic care and integrates different services. So they all have data, but they're not truly data-driven. And that's my goal, to figure out how to support that. I'm ready to take questions, and I also want to acknowledge my team of awesome students at Carnegie Mellon. That's us going to laser tag every semester. So they get the credit for designing and building Lilypad and helping me with that. Thank you.
I have what I think is probably a very big picture question.
Okay.
I think seeing the first few slides, you're talking about coordination, and it's something I've been thinking about too, in the context of sort of agriculture and trade in parts of sub-Saharan Africa, and people using mobile phones to coordinate supply chains and things. I think one direction I kind of imagine this might go is towards communication tools, parents talking with therapists, people kind of using plain language to communicate better about what's happening. And so it was interesting to see that the sort of language of coordination was data. What I'm wondering is whether there was pushback, not in terms of like the labor of entering data, but the value of data being that common language, or parents saying this data, is supposed to represent my child and it fails, or are who's demanding this data, and are people at different levels of this coordination team, grudgingly fulfilling that duty, or are they saying, this data is an incomplete story, and how might you even think about that in a design context?
Right.
If you were to tackle that question.
Yeah, no, you're totally right. One of my favorite quotes I got from parents as well as staff was, my kid is more than just a bunch of numbers. And there was pushback in that regard. There was the tensions that I talked about with supervisors just saying, this is what you're going to record and this is the data we need. And so my goal with the design process was to get at how can we capture data that's actually more representative of a human being, and present it to the different types of stakeholders in a way that's meaningful to them and useful to them. And I think when it's done right, I did see optimism from different types of stakeholders about what the data can do. And there's a lot of excitement with data science being really huge right now, and visual analytics being really huge right now, around what we can do with data. And my goal is to humanize it a little bit and to figure that out. Data can't be everything, but when it can be useful, how do we make it more useful? And my end goal is communication, but yeah, starting with the data and bringing people around the same data. Part of the reason I made an iPad is because I envisioned sort of people crowding around the iPad and looking at it instead of just sharing anecdotal evidence. And the strength of what I saw happening was people using their intuition about the kids to say, oh, I really think, this is what's going on and this is what we should do next. And that should totally happen, especially in a space like that where you need the human to interpret what's going on. And so my goal was just to bridge the gap between the informal stuff and the intuition and the anecdotal evidence, which is always going to be really useful with some data. And that maybe if they also saw some trends in the data, or got some notifications or communicated around the data, it might enhance the communication and the intuition part.
And then I have a related kind of follow-up question. I'm wondering if you spent any time with Garfinkel, who's an ethnomethodologist, and he wrote a classic in sociology called Good Organizational Reasons for Bad Clinical Records. And one of the insights had to do with the labor of data entry. Another insight had to do with the threat and kind of the mindfulness of people entering data about the possibility of audit, and the way that data was entered to make the case that needed to be made. Not, people in the setting, in that organizational setting collecting data are not the same as an outside evaluator collecting data who's trying to get to a truth, right?
Yeah.
The insiders are trying to make sure that they look like they've done their jobs, or are trying to kind of justify a decision that was made about a child. And did that conversation happen in
all the time? Yeah, that's a lot of what I saw. And so my goal was, the things that needed to be reported to a supervisor or to the state or whoever, make that as easy as possible, get that out of the way, automate that if possible, and then get at, what is being done just because they need to do it for somebody else, and what can actually help them internally make sense of what's going on with a child. And partially by saving them time with not doing it on paper, and getting them to more collaboratively sort of take responsibility for the data, and get more excited about what the data can do for them. I was hoping to, make it more internally useful for them. But that's always a balance too, and walking that line between what has to be done and reported and what is useful to them internally.
I'm wondering about how you came up with different types of visualization techniques, because as a designer, you can represent certain data in certain way that feels more personal for parents versus technicians, clinicians. And did you find yourself, as a designer, designing multiple different representations, or is there like a more flexible but universal ways of visualizing it so that any stakeholders could use?
So long term, I had thought about, how we might present it to parents in a more personal way, add the picture of the student at the very least, or, find ways to personalize it, humanize it. As a starting point, what we did was try to recreate what they already have. So as a way of easing the transition as much as possible and learning from it, I started as much as I could with recreating what they had. So that was where the line graph came in and the percentages came in. And we played around a little bit with, during our design process, of taking the data that they currently have and putting it in overlapping line graphs or bar graphs or percentage or pie chart, or, and we trying some of that with them. I think they tended toward what was familiar. And so even when we tried to give them something new and interesting that might help them see the data in a new way, that was sort of my goal with trying out different visualizations, it was too much of a jump. And so that's why we ended up with really just the percentages basically, and the full data values, and then the line graphs, which is what they knew really well. And that was how they were used to seeing the data. And I wasn't, within that 5 months, able to push them to something too new. And part of that is because, these are not statisticians or mathematicians, and they don't have a lot of time to look through the data. But and internally, the goal was really to just ease into what they were doing. But absolutely, I would love to long-term get them to look at it in new ways, and also explore with different types of stakeholders, even the parents or the kids themselves, especially the kids that are higher functioning, that are doing well, that might be transitioning out of the program. They're in sort of gold card status, is what they call it, and oftentimes will track their own data. So I would love to, that's one of the directions I want to take it, and look at what visualizations might be motivating for the kids and help them be more self-aware.
Yeah, sort of a segue to that, along the same lines. So you kind of divided healthcare between short-term and long-term. Short-term being more structured, and long-term being more organic, sort of flexible. I was curious because it seems like for one thing, healthcare coverage or insurance coverage is easier for short-term care than something that's sort of not very well defined. I'm curious if you think that sort of a data-driven. I mean, I guess is your goal partially to help bridge the gap to help achieve better coverage better insurance coverage for the long-term or more organic, customizable systems. And also, I'm curious if that's not the goal, maybe another goal would be to just basically empower healthcare providers and patients with their own ability to improve their long-term care benefit.
That was sort of the goal. So where insurance came in was sort of what we talked about a minute ago, what needed. So in this context, for the staff members to even get paid, they had to, part of the stuff they had to record was every 15-minute interval, what they were doing with that child and what services that child was receiving. That was for billing purposes for them to go through and even just get paid for their daily job. So that's mostly where I thought about it, where it came up during my field work, and where I was trying to separate out what was useful to them and what could be automated and get it out of their way as fast as possible. In terms of my overall goal, what I see a lot in my in HCI and in health informatics is sort of either systems being developed to help the providers analyze patient data, or empowering the patients, all the apps, all the health apps. And those are great, and my goal was to bridge that gap and to think about it more holistically and not one individual at a time, but how do we make data more accessible and informative and get everybody to coordinate around the same data so that we're bridging those gaps, whether it's between patient and provider or different types of providers and specialists. Yeah.
Okay, cool. Thanks.
Thanks.
Yeah, a kind of similar question to him. In terms of healthcare trends and things changing in terms of, there's more emphasis now on like public health, preventative, and sort of like wellness and the sort of softer non-clinical world. Do you feel like you see any, like, I guess, I don't know if you've thought about like, what are the next low-hanging fruit in terms of where this organic model works? Because it does seem like, I guess I don't know the answer, but like, yeah, the long-term unstructured organic thing, like, and I think, I don't know, like, for use cases, I'm like, I know like elderly care is like really coordination-centric and very chaotic. So I don't know if you've thought about, like, again, in the landscape of all these issues, what are the other like easier places where this might work the best or not work, or yeah.
So I briefly mentioned a community health clinic that I'm starting to work with in Philadelphia, and it's a nurse-run clinic. And what I like about them is that they have a similar view of like providing holistic services, and it's all in-home in a way. It's all in the same organization, but they mix. They have physicians, and they have your physical health, but they combine that with behavioral health and yoga and dance therapy, and they really look at sort of mind-body holistically. Oh, okay. And that's one reason I really wanted to work with them, because often health informatics focuses on the physical and focuses on the structured stuff. And so I think that's a nice next step for me, because I sort of went from physical health to like behavioral health, and maybe one that the kind of environment that looks at both. And how we can mix those types of data. So they, in-house, they sort of have your typical, weight, cholesterol type of physical health data, but then they do also keep track of what mental health referrals that person might get, and all in one place. I'm looking at how to bring that data together and make it accessible during meetings so that they can look at it together and get a holistic view of the patient. That's really their goal, and that's why I wanted to work with them on what kind of visualizations and representations of the data help them see their patient holistically and refer them to the right kinds of services.
Okay, so yeah, that sounds like two characteristics. Like, there are some organizations that are already like coordination hubs anyway, but it helps if a lot of it, again, isn't as purely clinical and regimented, because that'll introduce all those parties. Yeah.